And I know that those diffusion tensor imaging, that technology was really only in the realm of research for a very long time, and it's only been the last few years that we now have access to that clinically. And so my understanding was that at one point in time, it would take like a month for someone to actually like go through the data of that and create a report.
Mhm.
Um, what is the lag time on when someone goes to have that and when you have a report on your desk? And then what are the details in those reports?
Sure. So it absolutely used to be done. I In my fellowship, I worked a lot with MRI and post processing of these images, and so it would have to be by hand, which was really painful. But as a fellow, that was my job, was to do the things that other people did not want to do. But it really gave me an appreciation for how much um, computer power and time it takes. So on average, when the patient gets the MRI brain with DTI, the scan itself will be 30 to 45 minutes long, and then the post processing time with the report is about 2 weeks. So it's much shorter. And there are three things that I'm really looking for when we're talking about an MRI brain with DTI. The first is going to be if there are abnormalities in the diffusion, or rather the white matter tracts. So as I try to explain to my patients, these white matter tracts are kind of these connections, like these information highways that go between the frontal lobe, occipital lobe. It's the information channels, and the computer program, depending on the strength of the magnet, will look at 33 bundles, 48 bundles. And of those, we're trying to see how well basically the information travels. On a scientific level, we're looking at something called FA, or fractional anisotropy, which is looking at how well or how straight the white matter tracts are based on this model of diffusion of water. What that translates to is, of these 48 bundles or 33 bundles, how many are reading as normal or how many are disrupted? And so it gives me a number, a flat out number, one of 33 bundles, two of 33, for me to kind of go, okay, that's part one of three. Let me see if the rest of the MRI report fits that I could build into the story of, yeah, this is a concussion or a mild TBI. The second part is going to be, I'm looking for something called hemosiderin deposition, which is found on a special sequence called a susceptibility-weighted imaging. Previously, we had something called gradient imaging, GRE, but this is much more sensitive. And it's looking at, as I mentioned, hemosiderin deposition, which are these tiny, 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 like size the head of a pin of blood vessels that have been ruptured. And so when I tell this to patients, I've seen a lot of, oh my gosh, like very wide eyes, which completely understandable. But I basically tell them, when you're in a car accident and there's this acceleration, deceleration forces, there is this mechanism of a shear injury. And we're looking for those areas with hemosiderin deposition, meaning that shear injury was strong enough to cause small blood vessels to rupture. So SWI, or hemosiderin deposition, if they have it, also builds it into the picture of a concussion. And finally, we're looking at volumes of the brain. So it's not just the white matter and the gray matter, it's the corpus callosum, the basal ganglia. And oftentimes in our patients who have had concussions, there's going to be an asymmetry. The left side may have a few structures that are smaller than the right side, and it's out of the normal range. And so if I get those three components with the abnormal white matter tracts, hemosiderin deposition, and volume changes, for me, it's a slam dunk pretty much that the patient has sustained a mild traumatic brain injury or concussion. If all three aren't there, but still some of it fit, it helps me, again, build that picture that I could really tell the patient and their loved ones, no, this is real. This is something that the patient is experiencing, and we can document it objectively.
Yeah. And so, correct me if I'm wrong, on kind of a typical MRI, if somebody has a severe TBI, you might actually see axons that have been fully damaged, whereas with a concussion, there's more of, like you mentioned, the shearing force, which I kind of think of it as like you have a thread and the thread gets twisted. And so the damage is really happening on the inside of the axon with the microtubules that have been, the integrity of those have been affected. And so you don't actually see an axon breaking apart on an image, but with a DTI, you can actually still show that there's been damage to the axons with that kind of twisting, shearing force. And that's kind of part of what the DTI adds to the clinical picture, is being able to pick up on that type of damage.
Yeah, you're absolutely right. It's severe TBI, very devastating clinically, but easier to pick up on imaging. You can see whether it's on the with the hemosiderin deposition, you could see it in certain parts of the brain that are more obvious than with a concussion, and also on flare imaging, which is looking at um, basically making the white matter dark. You can see on severe TBIs the damage a lot easier than you can with a concussion. You're absolutely right. We're looking for those minuscule microstructure abnormalities with a concussion.
And then I know a lot of the research points to the fact that very often with a concussion, the frontal lobe is affected, and specifically the dorsolateral prefrontal cortex, which is involved in our executive functioning, the things that kind of keep us organized and moving forward in life. And so because you do the WAVI, are you finding a lot of kind of EEG evidence of problems happening within the functionality of that prefrontal cortex and this executive functioning center?
We are actually. So we see it the most with the event related potentials. So we're looking for something called a P300 wave and the amplitude. And essentially, as I explained it to the patients, we give them a sound stimuli during a set amount of time, and we're looking for how well the brain responds to it. And when the amplitude of the P300 wave is decreased, it points towards and leads towards, or rather points towards cognitive impairment. And the sooner you get the WAVI, the closer or immediately after the accident, the more sensitive the test is. Another reason for getting the test done ASAP after the accident. So I have had some patients where I would say it's 50-50. Their WAVI is abnormal and they're still struggling with neurocognitive symptoms, and then the other where the WAVI is abnormal and then they feel pretty well. I think that has to do
Hmm.
with age, medical comorbidities. I mean, my 20-year-olds, in my experience, bounce back so much faster than someone, 40 plus or 30 plus. There really is a beauty about being young. It's pretty impressive. So certainly we use the WAVI as a tool for cognitive, and then we reinforce that with the MoCA.